There you go. I have a breaking announcement that Rick asked me to share with you, so it'll help us bring us back from the break. I want to dispel any notions or rumors that Rick is retiring. He is not. He still is the PI on Chiz, and if there are any funders in the room, he'll be getting your card later. So raise your hand so Rick can take a note. And he's looking at 2013 and 2014, just so you know. So just wanted to make that clear. So welcome back. What we're going to do is shift gears a little bit to a topic. That was the fun. We had dessert first, and now we're going to talk about sustaining health reform in California and the nation, a small topic that will not be that interesting over the next 22 months, and there's not a lot of work and not a lot to do for it. I always say in my talks, particularly when I'm going out to community health centers and public hospitals, I start with the phrase that health reform is not self-implementing. And I know that may seem obvious to folks, but there are a lot of people who think the hard work is done. And I think our 5 panelists here will disabuse you of that notion either in their first or second sentences. That's the bad news. The good news is we have 5 brilliant folks here and thousands more like them in California and across the country who are working every day thinking about how to successfully implement the Affordable Care Act. And I think it is a full-time job and then some, and taxing all of the brightest minds and most creative folks and hardest working folks that we can pull together. What I'm going to do for this session is just introduce the panelists and get out of the way, because when you got smart people, let's let them go to it. So what I'll do is introduce each of them and then allow them to come up, and then we're going to leave some time for you all. We want this to be a conversation with you all, because I think hopefully you have a lot of questions about the Affordable Care Act, and you don't know it all or are not interested in it. So hopefully that you actually will have a lot of questions and that their remarks will stimulate your interest. So we're going to start with Kim Belcher, who is a senior policy advisor at the Public Policy Institute of California and former secretary of the California Health and Human Services Agency and a good friend, and also on the California Health Benefit Exchange. So if you did the Venn diagram of being important for the implementation of the Affordable Care Act, Kim sits very close to the epicenter, if not there. Then we'll turn to Anthony Wright, who's the executive director of Health Access in California. And Anthony has been a champion of health reform through the ups and the downs, and now he is a champion through implementation, looking out for the interest of California consumers and for all Californians. So really tying this to people and making sure we see health reform implementation all the way through to communities and to people. Then we'll turn to Andy Bondman, who we in California, I don't know if you know this, we have a head start on health reform. We did get a head start thanks to Kim's leadership on the exchange and other things, and also her leadership on, Kim negotiated a waiver with the federal government to allow California to get a jump start on some of the key elements of the Affordable Care Act. So Andy Bondman at from UCSF is going to speak to us about the Section 1115 Medicaid waiver. And normally that would be sleep-inducing to talk about Medicaid and the arcane research and demonstration waivers. But in fact, I'm here to say, not Andy's speech. Andy would not be sleep-inducing. No, not Andy, the topic. He would never be. But I'm here to say, actually, I think it's actually one of the hottest topics in health reform. And it's one of the places that some of the most innovative things are happening. And Andy's kind of at the center of that from his position at UCSF. And then Bob Kaplan has joined us, who was former UCLA professor at UCLA, is now the director of the NIH Office of Behavioral and Social Sciences Research, which I found out yesterday has a $4 billion budget, so he's got some juice to do a few things and change the health system. He is going to talk to us about public health and prevention. So one of the things that they're thinking about, a lot of the Affordable Care Act is around insurance and around expanding coverage and looking at the healthcare system. But Bob is going to remind us of all the elements that are in the bill or in the law and some of them that are not, of how we can move that agenda forward. And then finally we'll finish with Rick Kroenig, who is the Deputy Assistant Secretary for Health Policy in the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. He is on leave from the University of California at San Diego. And Rick will share with us the national perspective. So we'll first focus on California in keeping with the center's focus on California, and then telescope out and understand how is California kind of similar and different to other states in the country, and what does it look like when you're sitting in Rick's chair about implementation writ large of the Affordable Care Act. So with that, I will turn it over to Kim. Thank you.
Thank you, Peter. Well, if the term you use, Peter, is that the ACA is not self-executing, the phrase I share with my colleagues in the state health official land is implementation of the Affordable Care Act is not for sissies. And it's very true. Implementation of federal reform is not for the faint of heart. This is a time of extraordinary challenges in terms of the political uncertainty, the legal uncertainty, the fiscal constraints that many, if not all, states are grappling with. At the same time, it is just an extraordinarily exciting time to be a state health official, whether in a paid or unpaid capacity, and to be a part of what is going on here in California. And so notwithstanding the headaches and heartaches that is implementation of this remarkably complicated and challenging piece of legislation, the good news is that California is dealing with the headaches and heartaches of implementation, not whether or not we're even questioning whether or not to go forward. So I've been asked to talk a little bit about the exchange, which we are moving forward with as an element of reform. And I want to then touch upon a couple of the key challenges we're facing in 2012 to give you a sense of some of the priorities and issues that the board and our staff are grappling with. As I noted, we are fortunate to be in a state where policymakers understood the value of California rather than our respectfully, our colleagues in Washington, administering a health benefit exchange. For a variety of reasons, in particular because we have had quite a bit of experience with purchasing pools. Our elected officials back in 2010 understood an exchange, first and foremost, is a gateway to coverage. This is the place through which people will go to use that tax credit to purchase more affordable coverage and comply with the personal responsibility or the individual mandate that's a part of the Affordable Care Act. That an exchange or a purchasing pool can help organize a market in a way to focus competition among health plans and insurers more squarely on price and competition rather than avoiding or segmenting risk. And perhaps most importantly, California policymakers understood that an exchange has the opportunity to provide value to its members in terms of more affordable, higher quality coverage by purchasing on the behalf of individuals and small businesses, something we refer to as the active purchaser model. And that model, that authority we have, in some respects distinguishes California from many other states in terms of the tools and authorities we have to help move and shape markets on behalf of our members. The statute that within which we are working, both at the federal and at the state level, is clear. The federal government has provided us with a lot of tools, a lot of resources and authorities. But I also echo Peter's comments about the ACA is not self-implementing. It is really up to state policymakers and community leaders, providers, insurers, advocates. It is policy and practice at the state level, at the community level, that's going to determine whether or not reform really delivers on its promise in terms of expanded coverage, improved affordability, better quality, and reduced disparities, improvements in the health status of the people of California and all their diversity. Our board, once it was fully constituted this past summer, began by developing a vision, mission, value statement, which really provides the guidepost or the framework, if you will, for the policy and practice decisions that we are now beginning to grapple with in earnest. Our mission is to improve the health of all Californians by assuring access to affordable, quality health coverage. And we purposefully said all Californians because we recognize we're not going to be able to do that alone, but we are part of a larger ecosystem of healthcare coverage and service delivery. Our mission is definitely to expand the number of people who are insured in our state, but it's also to improve quality, to lower costs, and to address health disparities. How? By contributing to a more competitive marketplace that really empowers consumers to choose their plans, to choose their providers that they prefer, that they value, informed by good information. We've identified 6 values. I'm not going to go into all of them, but I highlight 2. One is, first and foremost, that we are a consumer-focused, consumer-oriented, consumer-grounded exchange board. We understand that it's the consumer who needs to be the lens through which we make all of our decisions, consumers in all of their diversity. And secondly, the second value I would underscore is catalyst. We really believe that we have an opportunity using our tools and authorities to really influence the market and to do so in a way to advance improvements in quality and care delivery. So what are some of the major challenges before us? Let me highlight two that I think really are critical, and if we don't get them right, I think we're going to have a lot of challenges in terms of meeting the promise and the hope of the Affordable Care Act. First is eligibility and enrollment. And this, in some respects, is kind of a technical set of issues that aren't terribly sexy, but the technical aspects of how we determine eligibility, how we facilitate enrollment, how we redetermine eligibility and keep people in coverage, absolutely at the core of our ability to achieve expanded coverage, improve access, improve quality, and fundamentally to improve the health status of the people of California. It is also fundamental to the exchange's objectives in terms of our financial sustainability, the affordability of the products we're able to offer consumers, and the leverage we have in the marketplace. So if we don't get this eligibility determination and enrollment piece right, then everything is going to be far more challenging to accomplish. The good news is the Affordable Care Act articulates a very strong and powerful vision that states are expected to provide a first-class customer service to facilitate the seamless and continuous enrollment in appropriate health coverage programs. This idea of a first-class customer experience, quite candidly, is not a long-standing value or tradition in public programs. I mean, to be very clear. But we have the opportunity, indeed the obligation, to deliver just that on behalf of the people we are serving. And while it is a challenge, and indeed it's threatening to some in terms of longstanding histories and business processes and institutions, it is core to our ability to successfully enroll and retain millions of otherwise uninsured Californians. We are moving forward with an information technology solicitation to build that IT infrastructure to advance the shared aspiration of the exchange, the Department of Healthcare Services, and the Managed Risk Medical Insurance Board, which administers our Healthy Families program, around eligibility determination and enrollment. We are building upon some really exciting work that is being led by a number of foundations, with the support of the Blue Shield of California Foundation, that relates to the public-facing web portal, the interface through which so many millions of Californians and all of their diversity will be going to access coverage and to enroll in health plans. And this is really it's called the User Experience 2014 project. That web portal project is really the first time there's been an effort made to create a first-class customer experience for our public programs and processes, and do so in a way that accommodates the very distinct and diverse needs of consumers, and really simplifies and facilitates this end-to-end process of securing and maintaining coverage. If we can get that piece right, then we are off to the races. The second issue I would touch on quickly relates to plan participation standards and quality improvement strategies. The Affordable Care Act establishes some very significant and important minimum qualifications to become what's called a QHP, a qualified health plan. And California policymakers said that's well and good, but we want to make sure that our exchange board is working hard to advance California's goals. So we have the authority to establish state plan participation standards in excess of those regulatory minimums. The direction we've been given is to provide our customers with the optimal combination of choice, quality, value, and service. That's pretty broad. So we say thank you, legislature, for that direction. And in all seriousness, we appreciate that. That's broad guidance, and now this is a very rich and important opportunity to shape what that means. And frankly, how the exchange defines and executes this selective contracting authority, this active purchaser role in the marketplace, is going to have significant bearing on how successful we are in terms of bringing better value, in terms of more affordable, higher quality products to our consumers, and have bearing on our ability, at least over time, to be a catalyst for change in terms of broader delivery system improvements. So we are just beginning a process with a consultant team that we're bringing on, reaching out to a broader group of stakeholders throughout our state to help inform our thinking about how do we think about and approach the development of processes, standards, and criteria for certification of qualified health plans. Just quickly, some of the activities that we will be considering, again with an eye towards advancing value for our members, quality and affordability, and over time being a catalyst for change in the delivery system and quality improvement more broadly. So a wide array of activities we're considering. For example, what additional requirements should we impose on or ask of our health plans and insurers in terms of certification criteria that reflect our goals around quality improvement, our goals around delivery system reform. Looking at standardizing benefits to really facilitate the ability of consumers to make meaningful comparisons of plans. Buying insurance in the best of cases is what many characterize as kind of a grudge buy. People don't get up in the morning and say, gee whiz, lucky me, today I get to buy some health insurance. And when you look at the demographic profile of the people who will be purchasing insurance through the exchange and our expanded Medi-Cal program, this is a very significant challenge. To make market work in a different way in terms of focusing competition on price and quality, the consumer has a very important role to play. And so we need to get meaningful information before them. We need to facilitate their ability to make meaningful comparisons across plans and products. Consumer incentives. We need to find ways to bring the consumer more meaningfully into this conversation about value. So we will be looking at opportunities to offer incentives to consumers to encourage that they use high-value services. And finally, if not initially, at least over time, I think we have a real responsibility to look at ways for us as an exchange board, as a major purchaser on behalf of millions of Californians, to do more to better align purchaser and payer incentives to really get at what are the underlying drivers of cost, both at the provider level and at the member level. So that's something we can look to do on our own. It's something we can look to do with other purchasers, whether it be CalPERS, the Medi-Cal program, large employers such as the Pacific Business Group on Health. So if not immediately, at least over the longer term, we have an opportunity to do more in my way of aligning those incentives. Our exchange board, I think, is uniquely positioned as an independent government entity to lead a very important conversation in our state about value and about how we collectively, not just as an exchange, but we broadly, can really help achieve better value in our healthcare delivery system, not just for exchange members, but really for the broader population. And that's what's exciting. That's what's exciting, and that's where we're really eager to get important input from a diversity of stakeholders in terms of these certification standards, in terms of who will be offered on the shelf as a choice. Let me say in closing a couple quick themes in terms of how we sustain our implementation and reform efforts going forward. In many respects, first and foremost, we need to be approaching our challenges from an implementation and operations perspective, not with an eye towards the past in terms of how our public programs and processes have been administered or how insurance markets or delivery systems have been organized and financed, but with a real commitment to stepping back, rethinking, recreating new processes, new paradigms. We need to be focused on the world of 2014 and what that needs to look like in terms of delivering greater value for Californians, not what the world has historically looked like in terms of our public programs and our private insurance markets. Secondly, building and sustaining reform is going to require state government to organize and operate itself differently. New alignments, new purchasing partnerships. There's tremendous opportunities with our public purchasers to work in closer alignment across a diversity of domains. Third, it means reaching out. I know it is not surprising to you all to learn that all wisdom and truth is not inherently resting in Sacramento.
It's in D.C.
It's in D.C.
Well, maybe not.
Notwithstanding the remarkable work of our state leaders and policymakers, it really is the broader stakeholder community is so critical to building the kind of partnerships and shared ownership and public will that is so critical and very absent in some important areas. And finally, moving forward and sustaining reform, it requires that we basically clone Rick Brown. In all seriousness, it requires evidence. It requires good, solid data. It requires information and analysis. And my final note about Rick, I was writing down some of the words that Deanna and Peter were using and matching them with some of my own. But visionary, leader, fundraiser, policy entrepreneur, evangelist, labradoodle, institution builder. The word I had used in my notes, Rick, was force of nature. Anyone who's had an opportunity to work with Rick knows he is in fact a force of nature. He does bring, as Peter says, a unique capacity to be relevant and to make an impact across that domain of policymaking. There are any number of examples where Rick's work has really helped raise the visibility of an issue, define a problem, set an agenda, help identify and analyze different options and specifications for determining policy choices, implement, and we all know so much policy is made in implementation, and then evaluate the work that's been done. So when I think about moving forward with reform, it is about evidence, it is about research and information, and I think that's it's a testimony to you, Rick, that you have done so much to inform the debate thus far, and that you will continue to do so going forward, and informed by the good work of you and the other smarty pants researchers out in the California community to deliver better value and, most importantly, better health for the people of California. Thank you.
So, good afternoon.
Good afternoon.
My name is Anthony Wright. I'm the Executive Director of Health Access California. Health Access is the statewide healthcare consumer advocacy coalition, which has been working for nearly 25 years in the goal of quality, affordable health care for all. I've been actually the Executive Director for 10 of those years, and I have to say that I've been just really pleased that in those 10 years there's been a very important guidepost in terms of good information, good advice, good policy, and just mentorship, and that was with Rick Brown for our organization, and not just for Health Access, but for I think I speak for a whole community of consumer and community and constituency organizations in Sacramento and around the state. It really has been great to do that. I know that we're loading, we're really like piling it on Rick today, and to the extent that I think a lot of people have thought that he's retiring, and so we need to say that he's not retiring. We don't want to do this too much for people not to. I mean, we may actually even have to do a misinformation campaign. We may have to, disinformation campaign, like, debunk the retirement along with death panels and all the other stuff that we have to do. But I mean, again, we just really appreciate it, and I agree with many of the things that was said about Rick, including Peter's introduction. Although I do wonder, as an advocate who believes in strong data, strong information, I just don't see the contradiction of having strong, rigorous data and then obviously following up with strong opinions based on that data. That, in fact, that's what we do. And, we're clearly...
And you were authentic.
What?
And you were authentic.
Yeah. And Rick has been that, and, he's done that prior to, he's been involved in Health Access through its founding and its beginnings well before I was there, but we've just been really pleased to have that partnership with the center, with Jerry Kaminsky, with the whole team at UCLA and the UC system, and so we really appreciate it. But and it's incredible partnership to do the work that we need to do moving forward, which is to implement health reform, and it's very exciting to work on that. And I want to, we use the center's research in our advocacy. We try to get it out there. Just this, today there was an article in the Sacramento Bee on the UCLA's medical debt study that I happen to be quoted in. So thank you to UCLA again. And we, put it out on Twitter. We have a Twitter feed at Health Access. I know somebody's Twittering this feed. Maybe some of you are as well. And so let me just be clear about, for those of you who are twitting, let me just say, if you take one thing from my talk, I'll try to get this in 140 characters. It is that one of the things that the ACA is a major achievement in multiple ways. And one of the ways that Kim was talking about is that it is actually the largest expansion of coverage since in multiple generations, since the creation of Medicare and Medicaid 40 years ago. And Kim outlined that through both the exchange and also through the expansion of Medi-Cal, which will be talked about in a little bit, millions more people will get into the healthcare system in a real way for the first time. But the other thing that I think is notable, and that I'll talk a little bit more about, it is that it is the biggest thing that Congress has ever done in terms of the patient's Bill of Rights, in terms of a patient's Bill of Rights for insurance consumers. For the first time, it finally puts a federal cop on the beat with regard to with regard to insurance abuses and consumer protections. This has long been a domain of the states. And so, but now there is some minimum standards that are in place federally. And that's really important because in many ways, California is a leader, but in other areas, California, especially in our insurance markets, in certain areas, we are the wild, wild west. We are the place where individuals are all alone at the mercy of the insurers with no market power and don't have the wherewithal, the purchasing power to get the best value for their dollar. And in fact, the individual market, as well as for small businesses, is the least efficient, most expensive way to get coverage. And so one of the ways that the ACA solves this is to create these exchanges that really can be that advocate, that aggregate purchaser, that negotiator for consumers. But I want to talk a little bit about the market in which the exchange operates in, and what are those ground rules. And some of those rules have started to come online, coming into place. California has taken extra steps to put them in line. So, for example, there are laws to, for example, get rid of annual and lifetime caps on coverage, so that people don't find that their coverage runs out at exactly the time that they need it. Last year, there was a bill passed on medical loss ratios to make sure that 80% of your patient premium dollar actually goes to patient care rather than administration and profit. And we had two different agencies having two different standards that were calculated in different ways, and finally we put something in law saying we're going to abide by a stronger, more consistent federal standard starting this year. And then one of the big things that's going to happen in 2014, but starting to be implemented now, is the issue of people being denied for pre-existing conditions. And this is obviously a huge thing, even for most of us who get coverage through employer-based coverage. We all can imagine the time at some point where where we don't have employer-based coverage, we don't have public program coverage, and we find that we are denied because of some condition we had in the past, whether it be something big like cancer, something small like heartburn, or just living over the age of 40. And so the thing that is, but this is also instructive of how we need to, this is not just one change. So one of the things we're doing is that between now and 2014, when those rules kick in, we needed a bridge program. So we created the Preexisting Condition Insurance Program in the ACA, which now, just last week, got over 7,000 enrollees, which makes it the largest pre-existing condition insurance program in the country. And people who would have not gotten coverage in any other way. And those folks are now getting coverage today. And the other thing that the ACA does is it says, for adults, we're going to have this bridge program, but for children, let's start that immediately. Let's get children not to be denied for pre-existing conditions starting in 2010. And they did. And that was in the law, but in the federal law. But what happened in California is that a couple of insurers said, well, if we actually have to cover all children, not just healthy children, but sick children too, maybe we don't want to cover children at all. And some of them actually started to withdraw child-only policies from the marketplace. And then the other insurers said, well, we don't want to be stuck with all the sick kids, so then they withdrew all their products from the kid market. So luckily, we were able to sponsor a bill by Assemblyman Mike Fuhrer and that Governor Schwarzenegger signed to say, in fact, if you don't offer coverage to children, then you can't cover adults either for 5 years. And lo and behold, all the insurers came back into the market on the day before the bill, December 31st, 2010. And so that's an example of how we as implementers have to sort of see what's going on in the world and make adjustments based on the policies, that the policy has some goals, but we have to actually recognize what's going on in the market and make adjustments accordingly. And in fact, there's opportunities to make improvements. And so one of the other things we did in that bill is said, also those children should not be charged more than 2-to-1 what any other child is charged for coverage until we get to 2014 when there's no differences in charges based on health status. And so again, it's an opportunity where we not just implemented and improved. And that's one of the things that we're very excited about working forward and doing in California is working on not just the premise, but the promise of health reform, taking the next step in terms of making these protections real for consumers. But I actually want to step beyond that to say it's not just about consumer protections. It's not just about protecting against an abuse here and abuse there in a marketplace. It's about fundamentally changing the market as a whole. Because at the end of the day, it's not just a bad actor here or a bad actor there. It's about that the market is structured with the entirely wrong incentives. Right now, insurers compete not based on cost or quality or service. The thing that is going to make the biggest difference for their bottom line is how effectively they can collect premiums from healthy people while avoiding sick people. It's called risk selection. That is how they are the most effective at being competitive, and that creates all sorts of incentives. So if they can avoid, and so what we have to do is we have to fundamentally change the way that insurers do business. Now, it's very exciting that there are some insurers that are actually willing to play with a different set of rules. And we may disagree on what those rules may be, but there is a recognition that this business model is a problem. And so that is what the challenge of the next couple of years is about, is not just saying that we're going to live in a world where people are no longer denied for pre-existing conditions, but actually getting to the world where insurers compete on cost and quality and customer service. And there's a gap there. And the ACA can only do the ACA by itself can only do the prohibition. It's up to us to get us to make this work in its own way. And so what are the things that we can do? We can, for example, do standardized products so that the insurers can't design their products so that there's some products that attract healthier people and then they can shift sicker people into other products. We can have reinsurance or risk adjustment so that insurers are not penalized. If they do wind up with a sicker population, then they're getting that they are made whole from that, and so that they're competing on how they provide care after they come in the door rather than who comes in the door. There's a range of policies that we have to put in place, and that we have to be very mindful to make sure that this works and that the system works on its behalf. So it is, it's a really exciting challenge, but it's a daunting challenge. We're going to need very strong and important data to do that, and so that's why we look forward to continuing to work with UCLA and our friends in academia to make this work. But at the end of the day, that is the goal, which is not to just provide consumer protections, but to fundamentally change the way that insurers experience the market to get coverage for everybody. And maybe it also involves including not just having the negotiator of the exchange, the regulators of the Department of Managed Healthcare, Department of Insurance. Maybe it's also a competitor, public options, including some of the county-based health plans that are out there. But the point is that this is the goal and the vision that we want to try to get to again, the promise and the premise of health reform. And so we look forward to working with you on that goal. Thank you.
Greetings. I'm Andy Bondman from University of California, San Francisco, and I bring you greetings from the north. Rick, long time ago when I guess I was a resident and moved from the East Coast to San Francisco, one of the first things I learned there was to never travel south. Actually, Rick played an instrumental role in changing my opinion about that. I don't know that, Rick, you would remember this, but when I had a bit more hair and was at a very young stage of my research career, I think I first met you actually at an APHA meeting in Chicago, and I was just toward the end of my fellowship, and I wouldn't normally have the courage to talk to someone who is clearly as famous as Rick. But Rick, you made that incredibly easy. You were always just an incredibly warm, supportive person from the beginning. And that meant a lot to me as a developing researcher. And it changed my opinion and my willingness to travel south. And I've benefited enormously from our years of being able to collaborate together and really see you as a close colleague. So thank you for doing that. And I know there are many people probably in the room who are mentees of Rick who know exactly what I'm talking about. So I just want to build a little bit on some of the comments that have preceded me. You know, I think with all the political posturing, we're in that what they sometimes refer to as the silly season of elections. And the media coverage of what's gone on with the Affordable Care Act, we can sometimes forget with these debates that sort of sound more like sporting events than they do actual social change opportunities. You know, just how incredibly important the ACA will be for millions of people in this country. And bringing it here to California, CHIS has helped us to understand just how many people will be affected here in the state. I've been asked to comment a little bit about the Medi-Cal part of this, and relying on some of the very good estimates that UCLA has generated, there's reasons to believe that maybe close to 3 million people will be gaining Medi-Cal coverage as a result of the Affordable Care Act. There are some others who've, there have been some questions about whether the numbers may be a little bit lower than that or what the range is around that, but that's a very significant number of people. And assuming UCLA is right, because I've never had any reason to question anything that UCLA has ever generated, that will be close to about a 40% increase in the numbers of people who are currently covered in the Medi-Cal program. So when you hear Kim and others talk about, implementation isn't going to happen on its own and so forth, that program is going to have a tremendous amount of growth. And this is going to cause stress and challenges for how they can go about accomplishing this. Now, one of the things that Kim touched on with the exchange are the challenges of how to go out and, in fact, offer the opportunity for people to get the coverage that is available to them. And this is going to be really a very significant challenge, and I couldn't agree more with what Kim's saying about how much effort we need to put into it. I just want to underscore it by putting fresh in your mind the thoughts of the kinds of people that we have to reach out to. They are people who have come from a very diverse background. Many of them may have limited English proficiency. Many may have issues of mental illness, behavioral health issues. Many may be in family constellations in which not everyone in the family is going to be eligible for the same kind of program, which will cause complexity in terms of how people will be able to take advantage of the opportunity that's there. And if we really want to fulfill the promise of this program, we really need to think about how to cleverly get out there and to reach difficult-to-reach populations to make sure that they're able to take full advantage of this opportunity. One of the things, Peter talked about the fact that we have this waiver in California. The waiver is a mechanism in Medicaid programs that the federal government has with states to allow Medicaid programs to get out from some of the administrative rules of the program and to try to do creative things with some of the resources in the Medicaid program. And California was very smart, in large part with Kim's leadership when she was in the role of the secretary, of renewing its waiver in ways that really allowed it to start to think about, and the name of its waiver is Bridge to Reform, really had on its mind what do we need to do to get this state ready to implement and to take advantage of the Affordable Care Act. And one of the significant pieces in the waiver is the low-income health program, which is a program that is allowing counties to essentially start to bring the adults who do not have dependent children, which is the very targeted group of individuals, the new category of individuals who are eligible for the Medicaid program under the Affordable Care Act, and to start to bring them in on a county-by-county basis with benefits that really start to approximate the Medicaid program. This not only allows counties and their providers to start to, what I'd like to refer to as kind of date the population and to form a relationship with them so that people start to have doctors and a place where they go for care, but also allows the counties to identify who are the individuals come January 1, 2014, who need to get a Medicaid card or need to be directed to the exchange to get insurance through that mechanism. So this is a tremendous opportunity that is bringing in federal resources to help counties to prepare the process toward eligibility expansion. Now, one of the things that the Affordable Care Act does, as many of you know, is that it actually builds in two ways toward expanding insurance. One is through the private marketplace, through the exchange, and the other is through the Medicaid program. And I don't know how many of you have sort of thought about why did Congress in its wisdom do this? Why did it in fact sort of continue to have these two pathways of expansion? Why didn't it all happen through private insurance expansion? And probably the short version of it is because, in fact, it turns out that expanding coverage through the Medicaid program is a less expensive way for the federal government to expand coverage than it is through private insurance. And this is very obvious if you go into the details of the Congressional Budget Office, which scored the various aspects of the legislation. Now, part of this is, of course, because states end up contributing some over time to the Medicaid program. But another big part of it is because providers historically are paid less through the Medicaid program than they are through private insurance. And that turns out to be a fairly significant way that the federal government can expand insurance in a less costly way. Except that there's potentially a problem with that, isn't there? If we're paying people less, we could be setting ourselves up for a very substantial problem with access to care. And we are already beginning in this state, as we know, with a set of workforce challenges. There are many parts of this state, in fact, the parts of the state where many of the people will gain insurance coverage, where there are already significant workforce shortages. The Central Valley is a very clear area to point to. So many inner city areas and many rural areas have shortages of physicians. And on top of that, we already know that California, unfortunately, does not have the highest participation rate of its physicians in the Medicaid program. There's nothing that requires a healthcare provider to actually participate in the program. And California, which has famously been one of the lowest reimbursing states among all 50 states in terms of how much it pays providers to take care of Medicaid beneficiaries, also does have one of the very lowest rates of participation of physicians in its Medicaid program. And unfortunately, we seem to be paddling in the wrong direction with regard to this. The state has, in fact, spent a fair bit of time in the courts trying to, in fact, lower provider payment rates over the last few years. There's a very high visibility case right now before the Supreme Court about whether, in fact, rates can be cut further to providers. So this sets us up for some real challenges with regard to ensuring that the coverage expansion will turn into an access expansion. Couple of things that we should really be thinking about in terms of implementation and how to, in fact, turn that around. One is the Affordable Care Act in 2013 will provide federal dollars to ensure that primary care providers are paid at a minimum Medicare reimbursement rates. And this is a very significant jump in how much primary care providers in this state can actually get reimbursed through the Medicaid program. On average now around the country, Medicaid reimbursement is about 65% of what Medicare pays. So that by going up to the Medicare rate, a very substantial amount of money will come from the federal government to increase substantially the amount that primary care providers can be paid for taking care of Medicaid beneficiaries. Unfortunately, this program will sunset in 2014. So it's just a 2-year period while the Medicaid expansion is ramping up. I think this is a tremendous opportunity for the state to consider this an opportunity to hit the reset button and to really think about how to move from thinking about primary care as something that you have to sort of pay for and can you pay less for it, and thinking about how to make an investment in a part of the delivery system that has been shown in this country and around the globe to be an efficient way to deliver services and to provide high-quality care in a more organized way for a patient population. So I think this is an incredibly important opportunity that the state needs to eye and to think about how to leverage those federal resources and to maximize them. And there's a couple of key issues that should be aligned with this. One is, as part of this waiver again, the state is very aggressively moving toward a coordinated care model through managed care delivery. As you probably know, the low-income children and their parents have been in a mandatory managed care program for several years in the Medi-Cal program in California. And in fact, by and large, that program has worked quite well for that patient population. Through work that's gone on at the University of California, there's been a demonstration that, in fact, more individuals in the Medicaid program who are in managed care are more likely to have a primary care provider relationship. There's been lower rates of preventable hospitalizations in managed care that went on in the fee-for-service program. So there are reasons to believe that maybe, in fact, this could be a helpful delivery model for other parts of the Medi-Cal program. And in fact, as part of the waiver now, there are steps underway of moving the disabled population in the Medi-Cal program into managed care as well in most of the urban counties around the state. This transition is in the process of going on. It's definitely a bit messy as people transition from fee-for-service to managed care, and we don't know yet how effectively that program will work for a much sicker patient population. This is a very important question, and we need to get it right if we're going to try to get the efficiency and the benefits of care coordination for this segment of the Medi-Cal population. And it's also an important test for yet another part of the Medi-Cal population, and that is the dual eligible, those who are dually covered by Medi-Cal and the Medicare program, as this is another very high-cost population within the Medi-Cal program that the state is already beginning to think about how to, in fact, improve care coordination for that population as well. There's one other policy that I think is key for us to align in making our delivery system work better and more efficiently for the Medi-Cal population, and that's the availability of federal funds for electronic health records. Just prior to the passage of the Affordable Care Act as part of the ERA stimulus bill, significant amounts of money, approximately $20 billion, was put into play to help physicians and hospitals acquire electronic health records. Recognizing some of the special challenges that Medicaid providers face in using and getting access to electronic health records, even more money was put on the table for Medicaid providers than for many other providers around the state. The state now has an opportunity and is just beginning to get ready to roll out the availability of those funds for individuals, for providers who are involved in taking care of Medi-Cal beneficiaries. I think this is a tremendous opportunity, again, to really think about not just putting computers in the office, but to think about how to align the use of that IT so that we can create a modern delivery system that is truly a system for Medi-Cal beneficiaries and gain the efficiency of what we really need. So we know that we have financial resource limitations in the state. We need to figure out ways to be more efficient in how we use our resources, and we need to think about, I think it's a tremendous time to think about aligning what we need to do on primary care with care coordination and managed care and with IT. These are, I could go on and on with the kinds of complex issues that the state needs to face in terms of fixing its delivery system. All I'll say is, and I'll echo, I love Kim's, she has the sissy, she's got the smarty pants. I don't have these clever ideas. I will say, I think it's a tremendous time that the state does need help. And I'm really thankful to be part of a group that includes many here at UCLA. It includes people at UCSF, at UC San Diego, and in fact, at all the University of California campuses. Taking a page out of Rick's book, frankly, I worked along with Rick to bring together the idea of faculty across the university campuses to try to create an alliance with the Department of Healthcare Services and the Medi-Cal program to help bring the expertise, the knowledge for both evaluating and for thinking of important implementation ideas. It goes under the name of CAMRI, the California Medicaid Research Institute. It's been a very successful partnership and one that I think and I hope will continue to grow. It's benefiting, the state is benefiting enormously from the work that Jerry Kaminsky and Dylan Roby are doing with regard to evaluating the low-income health program and what impact it's having in counties of identifying individuals who will ultimately be eligible for the Medi-Cal program. There's work going on at UC San Francisco through Janet Kaufman and Diane Rittenhouse and others that are helping the state to evaluate its rollout of information technology and electronic health records to providers. We are working with a team at UC San Diego and at UC Berkeley, Todd Gilmer and Carrie Graham, to help evaluate the movement of people with disabilities into a Medi-Cal managed care. So I think this is an important time, and California really benefits from a partnership between the university and the state. And again, a lot of this idea was generated with Rick's input, his collaborative approach to thinking about how to harness the strength and the resources of faculty across the campuses. I would say that as a disciple of Rick's, I really have benefited enormously from that, and I'm so thankful to be able to continue to have the partnership with folks here at UCLA and around the university and all of its sites to try to help implement this tremendous opportunity of the Affordable Care Act here in California. Thanks very much.
Well, thank you very much. It's a pleasure to be here. Let me begin this by making this somewhat autobiographical. I think many of you know that I started my career in a school of medicine where I served for many years, where the primary focus was on medicine. And then now I've gone into a job where the primary focus is on basic science. But sandwiched in between those two was a period of about 7 years that I spent here at the UCLA School of Public Health. And it affected the way I think about just about everything I do. So now I found myself in an environment where it's primarily driven by basic scientists. And I'm in the unusual position of being the advocate for public health. And so I've given a title to my talk today, and I call this, In Honor of Rick Brown, Don't Forget About Public Health. I think many of you know that Rick was a former president of the American Public Health Association, and he really embodies what public health is about. When I was invited to participate in this, I was originally going to talk about quality of care. And as I thought about it, I thought, what a great opportunity to talk not about quality of medical care, but about the impact of public health and public health interventions on the health of our population. At the NIH, we've had the opportunity to sponsor a variety of studies. One recent one was a study that was done by the Institute of Medicine and the National Academy of Sciences, where the committee looked at current life expectancies across different countries. And in particular, they looked at current life expectancies for people at age 50, primarily across developed countries. And one of the things that emerged was quite interesting. So I think we're quite proud of saying that our life expectancy in the United States has increased. So in the last century, it increased about 30%. On the other hand, what I was not aware of is that the life expectancy for Americans has not increased as rapidly as it has for people in other developed countries. So for example, in 1960, women in the United States, if you look at their life expectancy, remaining years of life at age 50, women in the United States were about 12th in the world, ranked about 12th. Now we're 47th. There are countries like Japan, which were much below us in 1960, who are now much above us. And so we have to ask the question, why is it that we're not getting the same gain in life expectancy that we observe in other countries? Now, one of the things that this panel did was they spent a lot of time trying to separate out the different components that make people live longer. And of course, the first explanation is, well, maybe we have a crummy healthcare system in the United States. But in fact, with a variety of different analyses, that was ruled out relatively quickly. So for example, if you control for various access of people with full access to health care in the United States, women in the United States still have this much slower rate of gain in life expectancy than you observe in other countries. We also know that if you look at the big successes in improvements in life expectancy in the United States, and the NIH is very proud to say that they contributed to the improvements in life expectancy that we observe, it turns out that at least there's some debate about this, but the National Heart, Lung, and Blood Institute argues that about 4/5 of the increase in life expectancy has occurred most recently, since about 1960, and that 4/5 of that is attributable to changes in deaths from coronary heart disease and stroke. And in fact, if you look at changes in life expectancy or deaths associated with cancer, they've been relatively flat over the course of time, as have been most other causes of death. We recently had an opportunity to look at 50 different publications that looked at the contributors to this increase in life expectancy associated with coronary heart disease. And largely that's occurred since the publication of the Framingham study, initially in 1960. It turns out that among these 50 publications, no publication attributes more than half of the gain to medicine. And so in the most pessimistic case, pessimistic for public health, it's about 50-50. That is 50-50 advances in medical care and 50% advances in public health, or modification of risk factors is included in that. Some of the analyses are about 80-20. And so the argument is that, in fact, public health has contributed mightily to the changes in our life expectancy in the United States. There's a group called the Oxford Health Alliance who has what they call the 3 for 50 principle. And they argue that 3 risk factors, that's tobacco use, poor diet, and lack of physical activity, contribute to 4 chronic diseases: heart disease, type 2 diabetes, lung disease, and some cancers. And together, these 4 diseases account for about 50% of all premature deaths in the world. So you might ask, well, with all of these benefits of public health, how are we doing? How much are we devoting to public health? Well, it turns out that another IOM panel has recently been looking at this. And again, it's my old job when I was in academia. We debated a lot about the methodologies. But we'll set that aside for today because the different methodologies will give you slightly different answers. But actually averaged across estimates, it's been estimated that we spend about 17% of our GDP, or we'll spend about 17% of our GDP on medical care this year. And we'll spend about 0.4% on public health. So roughly $70 billion, and actually that's a higher estimate that we'll spend on public health. So for each dollar that we spend in medical care, for each dollar that we spend on public health intervention, we spend about $40 in medical care intervention. Yet, if you believe the analyses that I suggested earlier, then in fact we get much more benefit from investing in public health than in medicine. Not that we don't want to invest in medicine, but in fact perhaps the ratio should be different. So I'm going to take a minute or two to talk about tobacco, something I used to work on when I was in San Diego before I came to UCLA, something I remain interested in. You know, worldwide, we're producing about 5.5 trillion cigarettes per year. There are about 1.3 billion cigarette smokers worldwide, and there are big consequences of this. So in the United States, there's still about 443,000 estimated deaths per year associated with tobacco use. The Centers for Disease Control estimates that this costs us about $96 billion in medical care costs and about $97 billion in lost productivity. Some years ago, I was asked by the Society of Behavioral Medicine to put a team together to write a position paper on policy options for tobacco control. And I did this with Tracy Orleans from the Robert Wood Johnson Foundation, Ken Perkins from the University of Pittsburgh, and John Pierce from UC San Diego. And we came up with 4 different policy options. By the way, this was 20 years ago. So 20 years ago, we said tobacco should be regulated by the FDA. We said there should be at least a $2 per pack tax on cigarettes, that there should be a total ban on tobacco advertising, and that healthcare reform, this is in the Clinton administration, should include treatment for nicotine addiction as a core preventive benefit. And I was actually asked to testify before the House Ways and Means Committee on this report. Now, this was a paper that was published in our own journal, in our own Society of Behavioral Medicine, and when it went for peer review, one of the peer reviewers said, quote, "These suggestions are far too radical and extreme. This may cause embarrassment to our society." But in fact, as you'll see, it's taken a long time, but all 4 of those recommendations have eventually been followed. Not that we recommended them, because others have as well. But I do want to say that the Centers for Disease Control now is reporting that if you look at all states in the United States, the rate of decline in deaths from cancers of lung and bronchus has been going down in the last decade about 0.5%, about 0.5% per year. where in California it's been going down 1.5% per year. California has been way out ahead in this, and I think that it's really a great testimony to activism and other things in California. But we still have a big problem, and we've recognized that this decline in tobacco use in California and elsewhere has stalled since about 2004. We know that there's about, in our country, about 3,500 kids who will smoke their first cigarette every day. There are substantial numbers, about 800 or so kids will become committed smokers each day, and we need to do something about it. So I want to just conclude by saying that we've looked at how we're doing in California. We're still doing relatively well, but we're slipping, and we're slipping in relation to other states. One of the things that we looked at in our old policy statement was tobacco tax. And by the way, this was an evidence-based statement, so we looked at all the evidence, and what our paper was mainly based on was the early evidence from California. Of course, always difficult to establish causation, but we think there was a reasonable case for causation. And at the time, California led the nation at Proposition 99 and Proposition 10 with higher tobacco taxes. In 2009, President Obama signed into law a provision that now raises the federal tax on cigarettes to $1 per pack. But in fact, the tobacco tax in California now has slipped behind. So we're now in the lower third of states at a state tax of 87 cents. To give you a sense, Rhode Island is about $4.25. Now, just to conclude, I want to say, well, what are we doing about it in the federal government? On June 22nd of 2009, President Obama signed the Family Smoking Prevention and Tobacco Control Act, which gives new authorities to the Food and Drug Administration. This was actually one of the things that we suggested in our policy statement 20 years ago. We presented the evidence that tobacco was an addictive product and it needed to be regulated by the FDA. And in fact, now, since 2009, the FDA has that authority. So the FDA is trying to do a variety of things. They want to promote youth tobacco, prevent youth tobacco use. They want to provide services for people who need to quit or would like to quit. And they want to improve public understanding of the dangers of tobacco use. And most importantly for us at the NIH, they want to develop better science because everything they do, they want to have based on the best and most recent science. And so we're doing two things at the NIH. This year in 2012, we have a new intramural program that's being launched to expand our activities in tobacco control. We also are funding NIH grants relevant to tobacco control. A variety of those RFAs are already out on the street. We're planning for 2013 to expand our tobacco training programs, and so universities like UCLA and other UC campuses will be able to compete for these large P50 awards, and you should expect to hear something about that over the next year. We also hope to expand a variety of different training programs to train the next generation of tobacco researchers. So by way of summary, Rick Brown was always a great inspiration to me, even before I came to UCLA. And I really have always admired him because that he's devoted his career to science, to activism, and to public health. And he's mixed those together, as all of the other speakers have said, in a most impressive way. I also wanted to emphasize that although this is a panel on health insurance, that health insurance is but one mechanism to improve health. And this is a lesson that I really internalized when I was a member of the faculty here at UCLA. And now, interestingly, it's become part of what I say at NIH directors meetings whenever I get an opportunity. And you'd be surprised, I think I'm preaching to the choir in this group, but you'd actually be surprised how many people who are very smart and very influential people don't hear these messages often. So we need more evidence-based activism around public health approaches to improve population health. And finally, I'd just like to say thank you, Rick, for being a leader and also for being such a good friend over these years. So thanks.
Good afternoon. It is a great pleasure to be here today and help celebrate and honor the work that Rick has done. Jerry Kaminsky and Peter asked me to talk about federal and state relations in healthcare reform and what we're doing at HHS to try to implement the Affordable Care Act. As Peter said in introduction, for most of the last 20 years, I've been an academic at UC San Diego. For the last 2 years, I'm a political appointee in the Obama administration. And one of the things I've learned as a political appointee is that it's often better to answer the question you want to answer and not the question that have been asked. So I'm tempted to ignore this question and just spend 8 minutes talking about Rick, but I'll actually pretend to be an academic again and spend a few minutes trying to respond to the implementation questions. As you've heard from Kim and Anthony and Andy, the policy challenges in implementing the Affordable Care Act are intense. Kim says this is not for implementation, is not for sissies. In HHS, we started after March 23rd, 2010 with the mantra, 2014 is yesterday, and we continue with that mantra. But in addition to the policy challenges, and I would say that the two main ones that have been outlined by Andy, the large expansion of Medicaid, creating challenges both in terms of enrolling tens of millions nationwide, perhaps 3 million new Medi-Cal enrollees in California, as well as challenges in having a delivery system that's capable of taking care of those new enrollees. So that's kind of one big issue, the Medicaid expansion. And then second, selling insurance to tens of millions of people, which is not a business that government has been involved in at all. The new exchange is going to be a sales agent and needs to convince lots of people to buy this product. And as Kim said, most people don't wake up on Saturday morning and say, gee, what am I going to do today? Oh, I know, I'm going to go buy insurance. What a wonderful thing. So this is going to be a very significant policy challenge. But I want to spend a couple minutes not on those policy challenges, but rather on an implementation challenge of sort of new dimensions in federalism. So we have long histories of social programs in this country with various mixtures of federal and state responsibilities. The Medicare and Social Security programs, entirely federal. The Medicaid program, joint federal and state, in which federal government sets some rules, but largely operated by the states with joint financing. Other models in mental health and education and housing, a variety of models of federal-state relations, but none that are going to look like what we're going to see in the Affordable Care Act, that will create new visions of how federal and state governments will be interacting. I want to spend a few minutes on kind of what we're doing at the federal level in implementation and cover three areas. And the first is what we're doing to create the ground rules or the guardrails for states that will be implementing exchanges. Second, talking about some of the technical assistance that we're providing to states, technical and financial assistance. And third, talking about what we're doing to get ready to establish federally facilitated exchanges in states that are not likely to implement their own exchanges. So on the first piece, the ground rules, we've been doing a lot, or what feels like a lot if you're working in HHS. As Anthony mentioned, last year, a variety of rules to implement early pieces of the Affordable Care Act, medical loss ratio and rate review, requirements that insurers cover 19 to 25-year-olds on their parents' plans. I wonder how many people here know a 19 to 25-year-old who is newly covered as a result of the Affordable Care Act? Yeah, quite a few. I mean, the estimates that we did in my office were that there are 2.5 million young adults newly covered. This comes from data from the National Center for Health Statistics and a few other sources. So, one of the early, I think, successes of the Affordable Care Act. But then looking towards 2014, a large volume of rulemaking to try to provide the ground rules for states in establishing their exchanges. Last summer, HHS issued notices of proposed rulemaking for Medicaid, the expansion of Medicaid eligibility, for the establishment of exchanges, and for what we affectionately known as 3 Rs, that is risk adjustment, reinsurance, and risk corridors. We are working now on finalizing each of those 3 rules and expect the final rules to be out quite soon. In the middle of December, the department issued a bulletin stating what our intention was around the essential health benefits package. How many folks here kind of some awareness of what was in this bulletin? You're in the Washington bubble, for us it seemed like very important, but yeah, out here it's like, who knows? So what we said in that bulletin was that we faced kind of three main choices. One was to offer a detailed list of covered services. One was to simply codify the statute, which requires that essential health benefits at least cover 10 categories: hospitalization, maternity services, prescription drugs, et cetera. Neither of those two choices looked like good ones to us. The detailed list of services would have opened us up to a lot of certainly political criticisms that we were, federal takeover of the healthcare system, dictating to tens of millions of Americans exactly what would be covered, but also serious policy challenges in a relatively short period of time. Kind of trying to figure out what that list might look like would have been hard. And a fundamental challenge that the Affordable Care Act says that if states mandate services that are not included in essential health benefits, they have to pay for the cost of those mandates. And if we had proposed a detailed list, unless it were the case that each service, that all state mandates were included in the list, and if we had done that, it would have been a rather large package. So if we left some state mandates out, then in the legislative sessions that have just started, we would expect that quite a few legislatures would be focused on trying to figure out, should they repeal the mandates, or could they figure out some way to pay for the mandates? And given the amount of work that needs to get done to implement the Affordable Care Act, we did not think that it would be a good use of legislative energy in this session to have them focused on whether or not they should repeal mandates. So rather than using proposing a detailed list or simply codifying the statute, which would probably not have been responsive, a key part of the statute is that the package of essential health benefits shall be equal to the scope of a typical employer plan, which if we knew exactly what it was, we could have saved ourselves a lot of work. We put a lot of work in trying to figure that out. And what we said in this bulletin is that there are lots of plans out there that don't actually differ all that much and that are all embodiments of typical employer plans. So we adopted an approach that is used in Medicaid and CHIP, in which states can choose from among a set of benchmark plans, the three largest small employer plans in the market today, the three largest CalPERS plans, the three largest plans in the Federal Employees Health Benefits Program, or the largest commercial HMO in the state. And any of those plans can be a benchmark and the basis of essential health benefits. To the extent that those plans don't include all of the 10 categories, they will need to be supplemented, and that will be needed in some cases. But we provided guidance on essential health benefits in the middle of December. We've received a few thousand comments on that, and we'll be soon issuing a set of frequently asked or answers to frequently asked questions to try to clarify the bulletin. We are working on further guidance that we will have out soon on actuarial value. The Affordable Care Act says that all plans, all qualified health plans should be either 60%, 70%, 80%, or 90% actuarial value, the so-called bronze, silver, gold, platinum. We'll be issuing guidance that tries to explain how that should be calculated. Guidance on cost-sharing reductions, low-income people purchasing through the exchange. Instead of getting the 70% plan, get help with cost sharing. We'll be issuing guidance on that. We're working with our IRS colleagues on guidance on what employers need to do to show that they're offering minimum value to be able to avoid paying the penalty for large employers who don't offer insurance. We're working on a notice of proposed rulemaking that will be out relatively soon to provide guidance about implementing the rating rules. So in 2014, there are 3-to-1 age bands. Older people can't be charged more than 3 times younger people. There's a requirement for guaranteed issue. As Anthony discussed, no more pre-existing conditions. We'll be issuing an NPRM to provide guidance on implementation there. So a long list of ground rules and guidance to help states that are implementing exchanges. We've also been providing financial and technical support to states. Every state in the union other than Alaska received an initial planning grant to establish exchanges. 29 states have received either level 1 or level 2 implementation grants. There were a half dozen or so states that received early innovator grants. So some numbers of hundreds of millions of dollars in financial support as well as technical assistance to states that are working on establishing exchanges. At the same time, we're working quite feverishly to get ready to implement federally facilitated exchanges in states that might decide not to operate their own exchanges. And all the kinds of issues that Kim outlined of the challenges facing the California Health Benefits Exchange, we are grappling with as well in the establishment of the federally facilitated exchanges, figuring out how to do outreach and enrollment and eligibility, plan management, as well as functions such as risk adjustment and reinsurance, calculation of the advanced premium tax credit, figuring out how to do that. We will be, I am sure, collectively breaking new ground in federal-state relations. I've talked about states establishing exchanges or the federal government operating federally facilitated exchanges. In both of these models, there's likely to be new kinds of cooperation and work between the federal government and the states. So that some states that are working very hard at establishing their own exchanges have come to us and said, you know, calculating the advanced premium tax credit, that is how much money will be coming from the federal government to folks who are wanting to buy insurance, that's not really something we want to be doing. Isn't that something the federal government can do better? And so we're working with states to try to figure out whether and how that might be possible. Similarly, a number of states that will be implementing exchanges have also been looking to HHS for help on implementing risk adjustment and reinsurance. And we're working on trying to see to what extent that may be possible. And on the other side, in states where we'll be operating federally facilitated exchanges, we're having conversations with states about what functions they may be wanting to do and may be able to do much better than the federal government. Certainly, departments of insurance have more interactions with health insurers than the federal government has in the past, and it makes sense to work with DOIs, or in California you've got the Department of Managed Healthcare, but here you're doing an exchange. This is not an issue here, but in states where we will probably be operating federally facilitated exchanges, there are likely to be new models of federal-state relationships there. All of this, of course, in an interesting fiscal context in which the premium tax credits are 100% federally supported, and the Medicaid expansion 100% federally supported through 2017, and then phasing down to 90%. So quite a lot of federal money in this context of new federal-state relationships. This will clearly create new challenges for folks who are working on evaluating the Affordable Care Act, and I'm sure that there will be effort here at the center, paying attention to what these federal-state relationships look like across the country, I think will be a key part of those efforts, and a key part towards figuring out about the success of the efforts. Let me return finally to why we're all here today, which is not to hear us probably talk about the implementation of healthcare reform. It's to celebrate and honor the work that Rick has done, and to amplify two of the things that have been said earlier by a variety of folks. In my grandfather's generation, Rick would be described as a peddler. He's a salesman. In my grandfather's generation, he would have been a schmata peddler, actually. I guess in this generation, actually, we call him an entrepreneur, and he's been called an entrepreneur a number of times. And I've actually had the pleasure of being the junior salesman with Rick on a number of efforts. I actually first met Rick in the Clinton administration, when Rick came to Washington, saw his work there, but really blossomed back in California. In 2002, Rick worked with Jackie Speer, who was then a state senator, now a congresswoman, on the development of SB 1414. And then in 2007, with John Burton and his staff on the development of SB 2. And I did have the pleasure of watching Rick and providing some support in those efforts. And he was a good salesman. SB 2 actually passed, although, as many of you know, it did eventually get repealed in a very painful referendum. I don't think Rick was, they didn't let him out enough in that sales campaign on the referendum. That was the real problem there. And then you've heard many times today about his success as an entrepreneur in building the center, and the funders in the room will not escape, I'm sure, without getting buttonholed. But finally, Rick is a wonderful, supportive, and loving person. I mean, there are 300 people, or however many people are in the room here today, because of that. I am fortunate to have Rick as a mentor, as a colleague, and as a friend. Thank you very much.
I'm going to send a message on someone's BlackBerry, whoever this is. Oh, okay. Good. I'll tweet for Anthony. He was actually tweeting what he was asking you all to tweet, so we'll go online for his followers. Thanks. That was intense, huh? Pretty darn good. So that is like a 400-level graduate seminar on the Affordable Care Act. What did we hear? We heard about the exchange changing the way the marketplace works, how people choose insurance, how insurance is regulated, sold, thought through, how the delivery system will be changed, Medicaid in all of its complexity, how do we simplify it and make it work better for folks, new federal-state relations and redefining literally our new federalism, which is something that's probably taken 100+ years to work out where we are today, and then a brief interlude about the things that actually produce health. In terms of from Bob. So I just want to take a moment to thank about it, but we're going to have questions. I want you all to stand up and get a chance to ask questions to them. But first, let's thank the panel for their rich remarks. And so we have two mics here on either side. So, and Jerry has assured me we have a little bit of time for some questions just to dig in on some of these issues.
Rating from CMS, but I'm also the immediate past chair of the Venice Family Clinic Board of Directors, and the unique problem that California has that many other states don't is the Affordable Care Act does not include non-citizens. And so LA County alone, we're talking about 500,000 individuals. And the burden of care for these individuals is going to fall on the community health centers, free clinics, public hospitals. And if we look at San Diego, which also has the same issue of so many undocumented individuals, they don't have a public hospital. They have a wonderful system of community health centers, but no public hospital. So how do you feel we should approach this issue? Notwithstanding the fact that we did pass the DREAM Act, that was good, and hopefully maybe sometime down the line we might have immigration reform, which would also be terrific. But short of that, how do we deal with the issue of undocumented individuals who are not included in the Affordable Care Act?
Okay, an easy one to start. I actually think we have got quite a few folks who could weigh in and say lots of things. Maybe we'll start with Kim and then go down the road, because it's Kim and Anthony, Andy, probably. Rick as well.
Do you want to change seats? You're good. You're good. It's interesting. In 2007, when Governor Schwarzenegger put forward a comprehensive health reform plan, we acknowledged that issue up front. The governor proposed covering all children regardless of immigration status. And the administration acknowledged that we can't ignore the fact that those children have parents, and that we have unauthorized immigrants who are going to need care, and they receive their care in the least appropriate, most costly setting possible, emergency rooms. We need to support our community clinics. We need to think creatively about alternatives. The Affordable Care Act, for a variety of reasons, wasn't able to kind of go down that path for, frankly, understandable reasons. California needs to own that issue and that reality, and I think we need to come together as a state, as a community, in thinking creatively. Our exchange board's mission, as I underscored, is to improve the health status of all Californians. And we were purposeful in that. So we want to be a part of that dialogue. Our hope would be, our contribution is to be a partner with other purchasers and look for ways to really shape and move the marketplace to bring, as I keep saying, better value. And better value is more affordability, more efficiency, better quality. And if we do our job well over time, that will free up some resources that can be allocated in different ways. So that's one observation. And number two, we need to think creatively and perhaps aggressively from an advocacy perspective about federal funding as it relates to the Disproportionate Share Hospital Program, DSH, which is an extraordinarily important lifeline and will become even more so for our public hospitals in the context of near universal coverage. Near universal is not universal. So it's a collective responsibility, and the Exchange Board wants to be a part of that conversation.
Very, very quickly, as much of an advocate as I and Health Access and a number of other groups are about the Affordable Care Act, we're not uncritical of it in terms of a variety of, there's a list of 10, maybe a much longer list of things that we would have done if we had our druthers, but this is what was able to pass through Congress. But the exclusion of undocumented was perhaps one of the most unfortunate and wrong for a variety of reasons. I do want to make a clarification that you said non-citizens, and that's not specifically correct. In fact, this actually expands coverage for legal immigrants, including recent legal immigrants, for the first time in a big while. So that I just want to make sure that that's clarified. And even for the undocumented, there are ways that it will help to the extent it helps the health system. It will help everybody in it. I mean, when you expand employer-based coverage, that's how a lot of folks currently get their coverage, now. When you invest in community clinics and the safety net, that's how do it now. So there are things that we can take a hold of and figure out how it works in the California context. But it also just underlines, I think, what Kim said, which is we need a safety net that not just survives but thrives in the new environment, and that's one of the big policy challenges in implementation.
Others good? I think that's a great. One of the other things I want to compliment the panel, even though Rick made light of it, they all answered the question actually very, very well. I think Rick, you taught us, Rick Brown, stay on message and get to the heart of the issue. So, question here.
Hi, good afternoon. I'm Claire Brindison, the director of the Philip R. Lee Institute for Health Policy Studies at UC San Francisco, and it's really an honor here to honor Rick. My question really has to do with the 800-pound gorilla having to do with the Supreme Court decision. And in your crystal ball, what is going to happen depending upon how narrow or wide that decision is? And is California going to be a leader in moving forward regardless of that decision?
Let's start at the other end.
Well, I'm confident that the Supreme Court will do the right thing here. And clearly, if it doesn't, it's got a lot of options from striking down the individual mandate, but leaving the rest of the Affordable Care Act in place, or from severing guaranteed issue and community rating. It could go all the way to saying, that the Medicaid expansion doesn't work, although interesting, obviously none of the appeals courts took that position. We will be facing challenges, if they do anything other than the right thing, but we will work at implementing whatever part of the statute is left in place. We'll get there.
I mean, I'll just simply say that of all the things that keep me up at night, the Supreme Court is actually not on the top 10 list. At the end of the day, 2 years ago, I don't think anybody questioned the constitutionality. It became a political thing. In the appeals court, you had conservative justices who are mentees and golf buddies of Scalia, affirming the Affordable Care Act, including the individual mandate. I have some. Maybe I'm wrong. Possible it is. I also think that at the end of the day, the number one thing that matters with regard to is the election. Is November. That's the game. And to be clear about the politics of it, even if the Supreme Court strikes down the individual mandate, it is eminently replaceable. There are other mechanisms that you could put in place to achieve the policy goal of getting healthy people in the system so they don't wait until they're sick. I mean, we had a vigorous debate in California about what was the form and exact way to do an individual responsibility measure. There's lots of ways to design one. It's eminently replaceable if there's a political will to do that. And that is actually what is the crux, whether it is technically whether it is a tax mechanism, or whether it's a mandate mechanism, or whether it's an auto-enrollment mechanism, or whatever. That's not the issue. The issue is the politics. But we'll see what happens. 3 days of oral arguments last week in March. Stay tuned.
Follow Anthony on Twitter. He will be.
I think Anthony's exactly right. We came very close in 2007, early 2008, in enacting a comprehensive reform proposal that really was quite similar to Massachusetts, quite similar to the Affordable Care Act. So it would be within the power and purview of our state elected officials to respond. Obviously, there's political and fiscal challenges attendant with a state-based response, but that would be within the purview of our policymakers, and I would hope they would step up, because I think it's clear reform would be very, very difficult to implement in a sustainable, responsible way without some type of personal responsibility obligation, a meaningful one.
So we'll do 2 more questions here, one on this side and then here.
Okay. Hi, I'm Nancy Gomez from Health Access California. And
I'm sorry, do you work for Anthony?
Yeah, I know.
So a challenging question here.
Did you miss the morning meeting?
I've heard him plenty of times, so I think I'm safe. But I think this question is directed to Mr. Cronick. And that is, we know that the U.S. Conference of Catholic Bishops, through their lobbying efforts, have been successful in getting an exemption to offer insurance plans to their employees that would not include no-cost contraceptive family planning services. And we know they now also want to extend that exemption to cover Catholic hospitals, Catholic universities, of which we know not all people that work at those institutions happen to be Catholic. I know there was a ruling recently, but I also know that the Obama administration seems to be softening its position and may eventually grant them this additional exemption. What do you think about that?
You don't really expect me to answer that question.
Yes, I do.
Is what I think about that.
So Rick, I'll frame it. So we've got an undocumented Supreme Court and now contraception, reproductive health. We are deep in a good conversation.
And let me just add, from the public health perspective, that abortion and women's care still seems to be the only medical service that is completely politicized, and we've got to do something to reverse that.
I appreciate the question, and I will convey those thoughts back.
Hi, my question kind of goes along with Nancy's. Thank you all for your presentations. My name is Selena. I'm here from the California Family Health Council. And one of the things that we're looking at is how quality comprehensive reproductive health care will be integrated and implemented through healthcare reform. And we heard earlier that the exchange is focusing on quality. And so my question is for the panelists, is how can we ensure that the newly covered under Medi-Cal and also the exchange have broad access to quality reproductive health care?
I'll take an initial crack and note that I think one of the big policy issues looming large in California is in the context of near universal coverage come 2014, when many, certainly not all, but many low-income uninsured Californians will have access to affordable coverage either through the no-cost Medi-Cal expansion or the low-cost subsidized coverage through the health benefit exchange. The question will become, so what's the future of what we characterize as our state-only programs? California, in the absence of near universal coverage, our policymakers over the years have said, certain programs, certain populations, certain services rise to such a high priority. We're going to have program, population, service-specific efforts. So we have, as a tremendous example, the FPAC program. We lead the nation in terms of providing near universal access to comprehensive family planning services to everyone up to 200% of poverty, regardless of your immigration status. So a question will be, so what's the future of that program, particularly in light of the expectation that the essential health benefits will include comprehensive family planning services? Questions will arise, though, about, well, what's the provider network? What's the nature of confidentiality and access, which is one of the real hallmarks of family planning, or the FPAC program? If FPAC goes away, what does that mean for unauthorized immigrants and their access to those essential services? So these questions around benefit design don't exist in isolation of other state programs that we collectively are going to have to sort through in terms of which programs continue, which ones are modified, which ones go away. From an exchange perspective, we are beginning this conversation around how do we think about quality? How do we think about delivery system reforms and improvements? What should be some of the goals that we identify and seek to advance through our purchasing, particularly in light of the populations that will be served? So we don't have a specific answer right now in terms of what will that look like, but these are some of the issues that not just the exchange, but really the broader policy community are going to have to navigate in the context of reproductive health.
Oh, go ahead. I mean, we don't have an answer, but some of us have opinions. And
but are they evidence-based?
Well, I mean, I think that, you know, on the issue of, for example, yes, on the issue of family planning for the Family PAC program, we are, you know, in favor, and there's a bill in the legislature, AB 714, that would do both. It would be, it's use the Family PAC program as actually a major gateway to get people into coverage, because there's a lot of those folks. There's 1.6 million folks in that program. A lot of those folks are eligible for either Medi-Cal or exchange, and that could be an exciting way to get millions of people in coverage on day one. At the same time, let's preserve the program so that no one loses access to those benefits if they're not qualified or they need it wrapped around or anything else. And those are some of the challenges we're going to have to talk about. I also just want to say on the flip side of family planning is maternity coverage, and that's also another area where California has actually taken a very strong lead. Actually, on July 1 of this year, because of a bill passed last year, maternity coverage will be part of the basic benefit package required in the individual and small groups markets. That was a 10-year fight, something that was very important, and in the duration of that 10-year time, we went through an individual market where 80% of the plans had maternity coverage to last year where only 13% of the plans had maternity coverage. And that was an example, again, the Wild Wild West, where the individual market was basically shedding a vital service for women, and thankfully, the Affordable Care Act created a structure by saying that's going to be required in 2014, that California could say we could even do it earlier than that. So again, another benefit.
Just a small additional comment. I mean, I think this theme, which has been brought up in the context of reproductive health, actually applies to an earlier question that came up as well when we talked about the safety net, for example. I mean, a big question that we all should be thinking about is historically the way we created our patchwork healthcare system is that we had all these kind of separate programs, and now we're trying to move toward a more mainstream system that everyone is in that system, and that clearly calls into question a lot of these kinds of specialized programs, and is it worth still making those investments in those specialized programs? And I think they're going to have to be taken on one by one and thought about what is the added value that comes from that kind of investment. In the earlier question about the immigrant population, which is a really an important set of issues, the point was made, gee, we may need to still make these special investments in safety net institutions to make sure that they're available not only for Medi-Cal expansion, but also for the immigrants. I think these questions will come up over and over again as resources are tight. We're figuring out how to create a mainstream program for everyone. I think an additional question that should be running through your mind when it comes to things like the Family PAC program is, okay, does this shift the providers who are going to be providing this service? Do they have the competency to actually provide it in the same quality way that was previously provided under the program from before? And so it's just it's an implication of it's not just about coverage, but where does that coverage get manifest in terms of actually delivering the service? And some of these things clearly have to get sorted out over time. There's no way we can answer them right now to know for certain how it's going to play out, but they are a very important set of issues about as we transition from a patchwork quilt to a more universal integrated system.
Thanks, Andy. That's a great place to stop, and thank our panel. And so if we could take a 10-minute break, we'll come back with a third panel about extending. So we've done a great job here sustaining it. Now we're going to extend the Affordable Care Act. So thank you.